Welcome to the Interventional Glaucoma podcast, brought to you by Elios Vision. Join us for unscripted discussions about the latest innovations in interventional glaucoma with leading ophthalmologists in the field. In this episode of the Interventional Glaucoma podcast, Dr. Cathy McCabe, Dr. Mark Gallardo and Mr. Dan Lindfield are back to continue the discussion about Elios post-operatively, covering topics such as post-op drop regimens, recovery times and results. Let's listen in.
Welcome everyone to the Interventional Glaucoma podcast brought to you by Elios Vision. I'm your host, Cathy McCabe. I'm delighted to be back again with my good friends now, Mark Gallardo and Dan Lindfield. And we have had such a great time in our previous two podcasts talking about Elios. First, how do we choose patients? Then how do we actually do the procedure? And I'm just so delighted to be back again with you talking about what do we do after that?
Thanks, Cathy.
It's a fun topic.
Mark, do you just want to tell us really briefly about yourself again for our listeners who might be joining for the first time?
Sure. Mark Gallardo. I'm a glaucoma specialist here in El Paso, Texas. I've been practicing for just over 17 years and became a very early MIGS adopter over a decade ago, and have been a part of Elios's clinical trials, both as standalone and with cataract surgery. And so I have had experience with the technology for about 2 years now.
And Dan?
Thanks, Cathy. Yeah, I'm Dan Lindfield from Guildford, which is just south of London in the UK. I have 10 years experience with MIGS, and I'm part of the prospective iStent versus Elios head-to-head study at the moment.
Great. And I'm Cathy McCabe. I'm a cataract refractive and MIGS enthusiast surgeon on the west coast of Florida. I'm excited to get into this again. I just briefly want to tell you again that Elios is an excimer laser. It creates 10 intraocularly and intraoperatively. We have a little probe that enables us to create 10 very precise ostia through trabecular meshwork that are about 200 microns in size. And we're talking about being able to offer that to our patients. Who do we select, which you can listen to a previous podcast for that. And then how do we actually do the procedure? Another podcast for that. And then this is the third in that series, talking about what do we expect with the treatment and how do we treat our patients afterward. So let's just dive right into that. What's your typical post-op experience, both for the patient and what should the doctor as well expect? Go ahead, Dan.
Thanks, Cathy. I think the easy summary is very similar to cataract surgery alone. I don't think that adding Elios or any of these small TM-based MIGS devices adds much to their post-op journey. There's a bit of a difference in counselling patients pre-op and peri-op, but post-op, it's typically a smooth post-operative course. I personally don't change the post-op drop regime from cataract surgery alone. So I'm using a combined topical steroid and topical antibiotic 4 times a day for a week, 3 a day for a week, 2 a day for a week, 1 a day for a week, and stop. And I give all my patients non-steroidals for macular protection as well. But I don't add anything to that for these transtrabecular devices. I do if I'm doing more canal-based surgery. So if I'm doing viscocanaloplasty or any trabeculotomy, I'd go a little bit more on steroid. But for these smaller ostia-creating devices, I'm using a standard regime. And I tend to see my patients at week 1, week 3, and week 6. And the week 1, when we've looked at our data of 40 eyes now, nothing is done at that time point. So I'm arguing to myself, do I really need to see them at week 1? I feel at the moment I do, because it's a new technology to me, and these are patients with glaucoma that may have pressure spikes. But actually, I'm probably seeing fewer pressure spikes after Elios than I would do on the cataract surgery alone in patients with glaucoma who are taking steroids. So I'm nearly at the mindset of just doing a 3-week and a 6-week post-op review.
And Mark, anything that you do differently than that, or different with the patients?
I really don't do anything different than what I'm doing with a standard cataract patient. I like to use the compounded triple medication after surgery, so it's a little easier for the patient. I typically just have them use it 4 times a day for a week, and then reduce it twice a day until their bottle's finished. And so it's usually about 3+ weeks total. But because it's such a clean procedure, I really don't do anything different at all.
The same for me, and we did switch to using compounded drops as well. And I think that simplifies the post-op regimen. But do you advise your patients to expect anything different than cataract surgery alone, or?
Mhm. I don't. I mean, in our last podcast we talked about blood, but anything we do to violate that inner wall, or excuse me, the inner wall of Schlemm's canal, we always have the potential of seeing a little bit of red blood cells floating in the anterior chamber. But like we said earlier, it's confirmatory. So there are some patients that might have some circulating red blood cells on postoperative day one, which might prevent us from having that perfect crystal clear vision. But again, it is confirmatory that we do have a direct communication from the anterior chamber of the Schlemm's canal. So I always highlight that as being a positive for my patients.
Yeah, agreed. Yeah, the visual recovery is a bit slower. I think we have to all argue that, but we are doing two procedures in one. And I think also just warning patients that their pressure, patients expect their pressure to come straight down and stay down, but we know it's multifactorial. There's a bit of inflammation, the blood effect, the steroid effect. You may be tinkering or adjusting their normal glaucoma drops they've been on for years. So they're going to be up and down a bit. And we train our patients to, really get into their pressures. They really passionately want to know their numbers. And therefore they hang on every 1 or 2 units that we find above or below. But I think telling patients that, until we're back to 6 to 8 weeks and the steroids are long gone, that's when we can really tell their outcome. Don't worry too much about week 1, week 2, week 3 pressures. They're going to be up and down as part of the standard journey.
Yeah. And I do keep my patients for the most part on their post-op drops, not just their post-op drops for their cataract surgery, but also keep them on their glaucoma medication in the post-op period. And I do that because you're right, they may have a response to the steroid. I think it also, as one of our colleagues one time said, that it gives them a second reason to celebrate. So they're celebrating right after cataract surgery because they see better. And then they can celebrate in the future when they're off of their steroid, generally is when I'm doing something with their glaucoma medication, when we're able to stop some of their glaucoma medication. So I like that it does separate the two happy instances for the patient, and it allows them to be protected in that post-operative period when they're also on steroids. So do you guys keep their glaucoma medication, or do you stop them immediately after surgery? What do you do?
So with MIGS in general, I typically just stop it. For the patients that I had in the clinical trial, because they were already washed out, as part of the protocol, we had to do a washout before the surgery. So they were already off of their medications. And even though they had intraocular pressures and sometimes in the mid-20s, on postoperative day one, I typically saw much lower pressures and didn't require reinitiation of treatment. So as a general rule of thumb, I typically don't restart medications, but I'll titrate them back on them if they need it, depending on where the pressure is, but usually after the first month.
Mm-hmm. And how about Dan? Do you do?
I think it's really difficult to actually answer that question because it's so multifaceted. There's so many factors to play. As a sweeping statement, if my desire is to reduce their medication, so if they are patients who are controlled with disease and pressure, and your reason to be there is meds, then I stop the meds really early. I want to know if I've got there, but I wouldn't judge it until I get off steroids. But I'm trying. Otherwise, I think if you do too many things later, it's too many extra visits. This is a simple, elegant, precise surgery. Bringing patients back 4 or 5 times to tweak their medication gets frustrating. So if my desire is to reduce medication, I do that early. If my desire is to reduce pressure, I'll leave them on it and then can maybe reduce it later on. But they're two kind of mindsets that I have as a kind of sweeping bipolar statement.
Yeah, because, it is true. It's so dependent on the patient. Were they already struggling with their medication? Did they have some other side effect from their medication that wasn't tolerable? Did they really not have good control with it? How bad is their glaucoma? That question was really unfair to both of you. So thank you for trying to fairly answer it. And so how long do you wait before you are pretty certain that you're seeing the full effect of the treatment? So you mentioned that it's not always immediate because there's so many things. They just had surgery, maybe they have inflammation, retained viscoelastic, you flushed out their collecting system a few times back and forth. So when do you decide, yep, this is everything we're going to get? Do you have a feel for that yet?
Yeah, I think my experience might be a little different, of course, because again, it was a part of a clinical trial and patients were already washed out. But I saw an immediate effect on post-op day one. And with the trial, we did see them more frequently, but I didn't see an elevation in pressures in almost, I would say almost all my patients. I did have a few that I had to restart or reinitiate therapy. But I saw an immediate response in these patients. They did have elevated intraocular pressures going into cataract surgery because they were already washed out of their medications. And so my experience is that it was an immediate effect, and it did have longevity.
Yeah,
Yeah.
I'd like to think 6 weeks really is when I guess there's two streams of thought, and where they combine is about the 6 week point. So that's when I'm starting to really judge it. I think you're right, Mark. I think our data suggests there's a really clear pattern emerging early on, but it's a data driven average mean pattern rather than individual patients. You can say exactly you're going to get what you want. But it teases us nicely into Ike, Ahmed, and Tissi are working with a big group of us, trying to work out a schema to try and work out when we stop and what we stop and how, to try and get some structure behind this, because it's the eternal question. It's what baffles us all, and we all do our different things. We all align on our surgical technique and our patient selection and our aim high, go low technique. We're all aligning on that, but we all still have quite varied mentality about stopping drops, and it's down to personal experience and patient factors. So we need clarity.
Well, I mean, I think one of the nice things about this particular technology is that we do have long-term data that's published and peer-reviewed, 8-year follow-up that's really shows how stable that pressure lowering effect is, even up to 4 years with significant reduction of medication. Really impressive data. But what's the longest follow-up you personally have seen, Mark, so far?
I have patients that are about 30 months out now, and I've seen the longevity. Of course, there is some debate as to whether how much of that is due to the cataract surgery, how much of that's due to the laser. But we're at a point now where we're exiting that point where the cataract extraction is a factor in the pressure reduction.
Right. And again, just the fact that we have some long-term data to even point to in something that's a relatively, newer discussion for us, talking about this technology in a more widespread basis. I think it's such a strength that we can look at that and feel some confidence. And what's the longest follow-up you've had so far, Dan?
Yeah, so I was not part of this trial until recently. So I've got 9 month data, but no patients were washed out. But I've seen the pressure come down. We're running at about 14 and a half millimeters, but I've not at the 6 and 9 month reviews. We're not adding medication back in again. So it's sustained, but yeah, like we say, there's a phaco effect. All of my cases are combined with phaco. So the phaco effect is strong. But yeah, we'll wait and see. But the head-to-head studies against other devices prospectively will be really exciting too.
And so far, what do you think is different for you than other maybe angle-based procedures that you've done, or what stands out in your mind when you think about this early experience that you've had post-operatively with these patients?
I'm getting the reproducibility of data. So what I find difficult with MIGS sometimes is that we tend to have more powerful MIGS devices, MIBS, bleb forming devices that have good power, but they're a big impact on patients' lives, or the very minimally invasive devices that have very little impact on patients' lives, patients' post-op journeys, but little, unreliable data. The mean is good, but the standard deviation, the spread is quite tricky. So I can't say that Mrs. Jones in front of me is going to get off her one medication. I can't be so confident. But what my Elios data seems to be it's quite tight. There's very little fluctuation in my results, so I can be more confident that if I do this, I will likely get the response that the data suggests I will. The unpredictability isn't there. I think that harks back to the 10 channels. My fellow deliberately does 4 where she thinks she's going to be, and then 3 high and 3 low, because we all think we know where TM is, but without a scanning EM or a really good view, it's really hard to know. And there's the parallax effect of where the probe comes at the angle from. So it gives us the opportunity to really spread those 10 channels around, knowing that even if half hit the jackpot, we get the result. Whereas if we have a 1 stent or a 2 stent or a 3 stent device, that chance is much lower.
I love that too, because, you know,
Mhm.
it is true that every single time you put a stent in, every single time you do a channel, it may not be perfectly placed, but when you have 10 chances, I like those odds a lot. What about you, Mark?
I've just been very surprised and pleasantly surprised at the efficacy of what we're doing with this technology. Of the patients that I've treated, a vast majority have maintained low pressures without medications. That they've all been at target, with the exception of a few where I've had to add rescue therapy. Um, but one of the things that I enjoy about being able to be medication free is just that improvement in quality of life. Practicing in the desert Southwest, every single one of my patients has ocular surface disease with or without medications. And of course, typically when they're on medications, that ocular surface disease is exacerbated. And there have been papers out there that have shown that the fewer medications a patient's on, the better their ocular surface index, the better their eye feels in general. Um, but not only that, we know that the better their ocular surface disease, the better contrast sensitivity they have. And I found that with this technology, because I have been able to maintain the vast majority of my patients without medication, it's really improved not only their quality of vision, but the sense that they have of their eye, where they're not as bothered by it. I say in my clinic many times that 80% of my day as a glaucoma specialist is spent talking about dry eye.
All of us.
Yeah. And when I'm able to minimize that need for topical therapy, those discussions are less. And
Mhm.
so I'm just very happy that we have yet another technology that we're able to use that's able to minimize that medication burden and maintain target pressures.
Yeah, and we know the data shows that 82% of patients will be medication free still at a year, which is pretty impressive. I know for sure if I had to use drops every day, I'm a terrible patient, is what I tell my
Hmm.
patients. And you know, I have dry eye, and I'm not good at putting in drops for dry eye, and I
Hmm.
feel the immediate result and relief. And if I had to put in something every day that I don't feel any different, but I know impacts the health of my eye, I would be terrible at it. So yeah, I think this is a great discussion. So just final thoughts, you know, what do you think? We've talked about the pre-op, the intra-op, the post-op. And when we think about all the different options we have for our cataract patients who have glaucoma, how does this rank in your mind compared to other options that you have for the patient? Go ahead, Mark, first.
Well, I like the fact that we're still preserving some of the aqueous pump and the trabecular meshwork, the blood aqueous barrier, while at the same time providing those channels through that diseased proximal system, because it doesn't have collateral damage because of the way the excimer laser works. I feel that I could always come back and do something later if I wanted to. I've always felt that I want to minimize my footprint in that nasal angle. As a glaucoma specialist, I'm always planning for the next step because I know there isn't a single procedure that works in everybody and lasts forever. So when I'm treating a patient, I'm already preparing for the next procedure because I know at some point in their life they're going to need something. And I feel with this technology, because we're not creating scar tissue and or removing the entirety of the proximal system, I can always come back and do something later. And so that's one thing that I enjoy about how this technology works.
Yeah, I think we're hearing more and more evidence from TM and canal-based sort of bench scientists that keeping that regularity, that homeostasis, that pump function is key. You know, the days of ripping the roof off Schlemms, I think we're going to move on from that because I think it doesn't fit with a kind of minimally invasive mindset if we are pulling it all out there. It may do in later disease, but we all know we should be operating as early as we possibly can, as long as it justifies the entrance and the risks. But what I find Elios does is just gives me that really, you've heard the word elegant, precise, precision, you know, collateral damage free. It's just a very, very, very nice way of getting neatly from anterior chamber into Schlemms without inflammation, without too much blood, and reproducibly. I think reproducibility is what really sets it apart for me. It's easy to use, and I know I'm going to have at least one, hopefully 9 or 10 conduits that get through, and we see that with the blood reflux. Unless you leave the pressure high, you will nearly always get reflux back out at the end of the procedure. You just know it's done the job you wanted it to do.
Yeah, I love all of those words that you said, the buzzwords too for me: predictable, precise, gentle, elegant, I think accessible. So it's accessible for the patient because it's something that we can offer them in different settings, especially in conjunction with cataract surgery. And I do want to remind our listeners it's not currently approved in the United States, but only for investigational use. But I think that the efficacy and the accessibility, it's a technique that can be adopted by the surgeon, so accessible to the surgeon to offer and accessible to patients to receive. So a winner in my mind, really excited. Been great being here with both of you talking about this exciting new technology, and looking forward to offering it to our patients more widely.
Thanks, Cathy. Thanks, Mark.
Yeah, thank you all.
Thank you for tuning into this episode of Interventional Glaucoma. Want to hear more? Be sure to click the subscribe button to be notified of new episodes. For more information about this episode's topic, read the show notes at eliosvision.com/OUS/podcast. Elios Vision GmbH is the EU distributor of Elios, manufactured by Emlaze GmbH, and the Fido laser applicator, manufactured by Vinert Fiber Optics GmbH. Elios is CE marked and licensed for use in the EU and is currently under investigational use in the US. Please refer to the full disclaimer in the show notes.